Mr. Smith is a 73-year-old retired college football coach that still coaches the local high school football team. He's got a history of COPD and a lung mass, and he was intubated 5 days ago for a COPD exacerbation and obstructive pneumonia. He underwent a tumor debulking yesterday and bronchoscopy to remove copious secretions that he was struggling with. Today, he's on PSV of 10 with a PEEP of 5 and an FiO2 of 40%. His prop overnight was at 90 mics per kilo per minute. He had a RAS of -5 when I came on shift, so I turned it off. And I've been waiting for him to wake up so I can do a spontaneous breathing trial. He's at a RAS of -2 right now, and he's CAM positive.
How much sleep did he get overnight?
Well, he's sedated. He didn't get any sleep last night or for the past 5 days.
Looking at the x-ray from today morning, it looks like he's getting nervous sucking again. Melody, are you getting a ton of secretions out when you suction him?
No, I've been trying to suction him all morning, and he sounds so junky. I'm not getting anything up when I suction him. Yeah, I'll order percussive therapy in 3%. Dr. Kaul, you want to bronch him?
Sure. I think that's a good idea. When, let's get ready to give him sedation and get him sleeping pretty good while we prepare to do the bronchoscopy.
Oh, for the love of all things respiratory, percussive therapy and hypertonic saline nymphs. You know, I was really thinking that maybe we could actually wake the patient up fully and mobilize him and see if maybe we could get him to clear his secretions on its own. And then maybe we can try to extubate him. What do you think, Dr. Ghionni?
Melody, I think you're right. Kali, before you put in that order for 3% and chest PT, let's think about this for a second. 3% NAC, these are all mucolytics, but they're also bronchoirritants, which is why the patients cough after they receive them. So maybe for a patient with COPD and reactive airway disease who's already bronchospastic, this might not be the best idea for the patient. The AARC, or the American Academy of Respiratory Care, actually recommends against the routine use of mucolytics in patients who are intubated with atelectasis because of unclear evidence of benefit and possible harm. Not to mention it makes the patient uncomfortable because of the bronchospasm and coughing, but it also is a high burden on the respiratory therapist to administer.
Isn't it cruel to have him wake while he's intubated? What if he self-extubates when you sit him up?
Well, he has delirium, so I don't think it makes any sense to continue giving him deliriogenic medications. I think that mobility will help treat that delirium and help him tolerate the ET tube, or better yet, just be able to get that out.
Well, let's be realistic. He's going to need the bronch anyway. So why don't we get prepared for that, get done with the bronch, and go from there.
But we tried a bronch yesterday and it didn't work. But the reason this guy is so plugged up with secretions is because he's been stuck in the bed, not moving for days and days. It's been 5 days. The bronch yesterday didn't help clear secretions. Realistically, if we had maybe gotten him up moving and walking on day 1, he probably could have been extubated by now. He really should be able to be up and coughing and clearing his own secretions and moving around. I don't want this guy to be a chronic ventilator or a trach patient, and this is what we're setting ourselves up for if we're just doing the same thing over and over and over again. A bronch only gets down so far.
Okay, but it's inhumane to keep people awake while they're intubated. So why don't we run a low-dose propofol drip, keep the RAS somewhere near -1, and then see if we can try to set him up during that time.
I think the patient's propofol is making him really sluggish. As we know, we want a patient more lightly sedated so they can participate in mobility exercises, maybe even sitting up on the edge of the bed and coughing and expectorating the mucus that we're trying to suck out. I think if we keep the sedation going at the same level, we're going to be left with the same problems, which is a never-ending cycle of the patient being sedated, then us waking him up and him being agitated, and then us resedating him, and then starting that cycle over and over again, all the while he's not getting the early mobility and interaction with his family. Maybe if we lighten the sedation and use that agitation, as we're calling it, as momentum to get him to the side of the bed and maybe even standing up with the endotracheal tube in, he might start coughing and that will expectorate whatever we're trying to suck out. I'm sure it's also going to absolutely wipe him out for the day, and he'll sleep tonight without the need for other medications to help him sleep. And we know that when patients' sleep is protected in the ICU, there's less chance of delirium, which is a major source of morbidity and mortality in the ICU population.
He's probably also going to need quite a bit of reorientation. I'd rather have him fully awake so that he and I can communicate and I can understand what his needs are. Otherwise, it's going to be really hard for us to keep him calm.
Communicate? He's intubated. He can't communicate. Listen, I know it's counterintuitive to decrease sedation and get him moving, but right now what we're doing to him by keeping him sedated and in the bed is actually damaging. And his delirium is putting him at risk of long-term brain injury. Right now, he's already lost about 10% of his muscle function, and every single day we're keeping him sedated and not moving is increasing that muscle loss minute by minute by minute. And really, his quality of life depends on us getting him awake and moving. Even keeping him at a RAS of -1 or -2 is extremely dangerous. Okay, fine. Go ahead and try it. Good luck with that. I'm going to have to see it to believe it. Oh my gosh, Kali, the patient looks amazing. I just got so much junk out of him when I just suctioned him right now. And I have him all the way down to CPAP of 5 and 40%. He doesn't even need pressure support now. He's sitting in the chair too for the last 30 minutes. guy looks amazing. And you know what? I don't think he needs percussive therapy anymore. Seriously? Didn't he go crazy?
He was pretty miserable sitting up and coughing a lot until we suctioned him, which really helped to improve his work of breathing. And now he's happy as a clam sitting in the chair next to his wife.
All right, let's get him extubated.